People skiing for longer, being more involved in change of direction sport, it's an injury that is probably increasing in incidence. One of the good things about the injury is that almost all of the time it's something that heals despite the patient, and it is something that rarely needs something doing to it. That said, there are some specific indications for surgical treatment and more active treatments. And one of the things we'll talk a little bit about is when the MCL is injured along with other injuries, with other ligaments rather, and how that there is an increasing trend to repair the ligament early in some higher performing athletes. So those are some of the things that we may cover as the talk goes on. So, as with any particular type of injury, if we're thinking about how we're going to diagnose that, we need to have a bit of a system. And at medical school, they teach us that the history is usually the most important part of making a diagnosis. And with this particular injury, that is definitely something that's true. And listening carefully to the patient is one of the key things in distinguishing medial collateral ligament injuries from other causes of medial knee pain, like a meniscal tear or a medial compartment chondral injury or osteoarthritis. So patients that injure their medial ligament will almost always describe having had some degree of valgus force associated with their knee. It doesn't necessarily need to be too gross, and there may be some degree of uncertainty, but there will be some trauma and usually an impact to the lateral aspect of the knee. There are a very small group of patients that can get an overuse mechanism. And so that's been described in swimmers that do a lot of breaststroke and water polo swimmers. So an analogy for that might be people that injure the ulnar collateral ligament in their thumb. So that can be hurt, skiing and catching your thumb on a ski pole, but classically it was called gamekeeper's thumb, and it was an overuse injury, and the ligament became painful and incompetent because the patient was, or the gamekeeper was subjecting their thumb to repeated stress. So that's something to kind of keep in mind. If the patient hasn't had a valgus injury and they're not a breaststroker or a water polo player, they probably haven't had a medial collateral ligament injury. Some of the other things to talk about are things that may point towards other associated injuries and may go along with medial knee pain. So obviously, if someone's injured their medial ligament, we'd expect them to have pain that's fairly localized around the medial side of their knee. And usually it's around the proximal part of the medial collateral ligament, around the medial femoral condyle. Swelling in the region of the medial collateral ligament is common, but an effusion, so swelling of the knee, is not. So it's an extra articular ligament, and you have to have had a much more high-grade injury to the ligament in order to get bleeding and a hemarthrosis. So if the patient describes a generalized swelling, that may be something that suggests a different cause. Patients will describe a sense of vulnerability or instability, but the knee frankly giving way would be uncommon with a medial collateral ligament injury, and that may prompt you to think maybe they've had an associated injury to their anterior cruciate ligament, which sometimes goes along with an MCL injury, or maybe that they have had an injury to the medial meniscus rather than the MCL. Similarly, mechanical symptoms, the knee frankly locking and jamming and catching, that would not be in common with in keeping with an MCL injury. And you'd be thinking more along the lines of a loose or unstable meniscal tear. And just the ability to weight bear, that may have an impact on determining the severity of the injury and deciding whether you may want to investigate that further. So if they're unable to weight bear, then you're more likely to arrange an X-ray, I think. Older patients are less likely to have injured their MCL, but obviously anyone can have a valgus injury. And so I think the most common mechanism that I see in older patients who injure their MCL is a skiing mechanism, where they've had a valgus stress after they've caught an edge, or they've been skiing in some icy or slushy snow. But most of the referrals that come in older patients, and I guess by that I mean patients kind of my age, 40 plus, but more 50, 60, and 70, they may be diagnosed with a medial ligament injury because they have medial knee pain, but they're more likely to have an injury to the medial compartment, so articular cartilage or medial meniscus. So particularly in the kind of middle age, I'm loath to call myself middle age, but there you go, but middle age or older patients, I would be starting to think this patient doesn't have an MCL injury, and that they have to convince me that they do, rather than saying, look, this is an MCL injury and we'll treat that. So that is just a kind of tip that maybe is useful when you're thinking about these patients. The clinical examination is obviously the next part, and there are some tests that are specifically designed to look at the medial collateral ligament, but it needs to be done as part of a more comprehensive knee examination. So the role of the examination really is to diagnose the medial ligament injury, but also to exclude other injuries and other things that could be causing similar pain and similar symptoms. So this is an example of a stress test used to diagnose or to look for pain or laxity with the medial collateral ligament. So using my left hand there to push the knee into valgus, and my right hand to pull the ankle into a valgus position. And so patients with an MCL injury will have a degree of pain, but if they have a higher grade injury, they're going to have a degree of laxity. And so if you're not sure, comparing to the other side is a good idea. One of the things to remember with this test is, while it's quite sensitive, the specificity is pretty poor. So anything that causes medial knee pain or causes the knee to be swollen or painful is going to be sore there. And so what you're really trying to say is the ligament loose? Can I reproduce the patient's problem with this test? And first we do this in 30 degrees of knee flexion, which kind of isolates the medial collateral ligament, and then we move on to do that test in full extension. And if the patient is also loose in full extension, it implies a more significant injury, and that they may have also injured the posteromedial corner. So that's a good test specifically to look at the medial collateral ligament, but remember, it may produce pain and lots of other diagnoses. Palpating around the medial collateral ligament is really useful, and most patients will have pain a little bit higher to where I'm palpating there. They'll have pain and tenderness over the medial femoral condyle. So the vast majority of MCL injuries will be injured around the medial femoral condyle, and that will be the point of tenderness, which is a little different to patients that have a meniscus tear or have medial compartment change, where they'll be more tender around the joint line. So there's a degree of vagary with that, but that's a good rule of thumb. I mentioned before that it's uncommon for patients who have a medial collateral ligament to have an effusion. If you have a more significant injury, a higher grade injury, you can tear through the joint capsule, and that does tend to create a hemarthrosis, so the knee will bleed and will swell. Similarly, you can have some associated impaction injuries, so we'll see an MRI image of an impaction injury, and that can also make the knee swell. So I guess the point I'm trying to make here is, remember to examine the rest of the knee. And a patient that has a big, fat, swollen knee, be a little bit reluctant to diagnose an isolated MCL injury, and just be aware that there are other things that potentially could be causing that patient's problem. So the examination, you want to assess the MCL specifically. You need to remember the other knee ligaments, and in particular the cruciate ligaments, as they can often be injured along with the medial ligament. And an effusion or knee swelling is not generally in keeping with an isolated MCL injury. So just bear those things in mind when you're looking at a patient's knee. Moving on to have a look at how we might investigate or image these patients' knees. There are a variety of different things that we can do. And again, why are we imaging? Again, we're looking to diagnose the patient's problem, although most often isolated medial ligament injuries are a clinical diagnosis, and we're not really relying on imaging studies to kind of confirm that. But we're also looking to exclude other problems and to look for, for example, multi-ligament injuries. So everyone, I think, who has a kind of more significant injury should have an X-ray. And sometimes it's a bit of a hard sell to the patient, because they say, well, look, X-rays show us bones, don't they? They don't show us any of the ligaments or soft tissue structures. But really what we're trying to do with that is look at the overall alignment and look for fractures, so other things that can cause acute knee pain. And this X-ray at first glance looks pretty normal, but if you have a look more closely around the lateral aspect of the lateral femoral condyle, we can see a small avulsion fracture, which is called a Sagon fracture. And when you see that, it almost always implies that the patient has injured their anterior cruciate ligament. So we can almost fairly definitively make that diagnosis based on looking at one single X-ray. So the X-ray is really useful. It's not to look at the medial ligament, it's more to look at associated structures and to exclude other things. The next test I want to talk about is an ultrasound. So ultrasounds in New Zealand anyway are being used more and more and more, potentially for no good reason. So they're actually not a very good test around the knee. We can see on this MRI, on this ultrasound, that you can easily define the medial collateral ligament. This is a normal ligament. And you can get a bit of an impression about what the periphery of the meniscus looks like. But generally, it can be confusing and I think falsely reassuring. So your decision making for patients with MCL injuries is around how loose the MCL is, not what it looks like on an ultrasound. So the ultrasound scan, might suggest that the ligament is not too bad, when actually it's looking not too bad because the fibers are sitting in close approximation. But then when you add a valgus stress, everything opens up. Similarly, you might see that, look, the meniscus looks pretty good here, but you're really only seeing the very peripheral part. So in my view, ultrasound's not particularly useful. You can see the ligament, but it's not helping you make a decision because it's not telling you whether the ligament is loose. What is a much better test is an MRI scan. And this MRI image shows us an injured medial collateral ligament. So if you can see my cursor here, this lower part of the medial collateral ligament looks pretty normal. So you can see it's a fairly fine black band. But as we come up closer to the orange area here, you can see there's a lot of white signal here, which is edema and soft tissue swelling. And the medial ligament looks quite wavy and less well defined. So that's a moderate to high grade injury to the medial collateral ligament. What we can also see on the scan over here is that there's some increased signal within the bone. So what that means is the bone here looks a bit whiter and brighter, certainly than the bone down in the middle of the tibia here. And so that is usually an impact to the lateral side of the knee. So we see this bone bruising from the impact, and then we see this medial injury to the medial collateral ligament. So this is a patient whose knee may well have swollen more often or more impressively after the injury, because in addition to the ligament injury, they've also got some bone bruise. And that's something that's relatively common. If I show you this case, this patient's also injured the medial ligament. We can see that it looks a little bit poorly defined there, but they've also injured the anterior cruciate ligament. So I would argue that most patients with an isolated MCL injury probably don't need an MRI scan, but when there's uncertainty about the diagnosis and whether it is truly an isolated injury, and whether there may be another component to it, or whether you think that clinically that there might be another injury, the MRI scan becomes really useful because it helps us prove, yes, they've torn their MCL, but yes, they've also torn their anterior cruciate ligament. And then down here in the tibia, we can also see this bone bruising, which is a more characteristic impaction injury pattern with an ACL injury. So that's an example of an ACL MCL injury. This patient here has a high-grade injury to the medial collateral ligament, but if you have a look in the intercondylar notch here, you can see that the anterior cruciate ligament looks normal. But if we look now on a sagittal view, we can see that their PCL is torn. So the PCL normally is a nice uniform black structure that runs from the anterior aspect of the tibia, the femur, back to the posterior aspect of the tibia. We can see a little piece of PCL down here. Through the middle, there's really no PCL, and then we can see the proximal part here. So that is an example of an ACL PCL injury. So really, my suggestion is that most patients who have a significant or traumatic injury to their knee should get an X-ray, and it's really looking to exclude other problems that you might miss. I think in the context of medial knee pain, there's not much role for ultrasound, partly because it's not helping us make a clinical decision, but also because it's a suboptimal study or less useful study than an MRI scan. And so MRI scans for most MCL injuries are not going to be needed, but when you think that this patient has had a higher grade injury, if it just doesn't quite make sense because the knee is quite swollen, or if you think maybe they've had an associated injury, an MRI scan is an excellent next step. And then I guess having made a diagnosis either of an isolated MCL injury or a combined ligamentous injury involving the medial collateral ligament, we need to make a treatment plan. And in some situations, you might not really need to treat the patient at all. So low-grade MCL injuries generally get better despite the patient. And a lot of patients, particularly those that are not particularly active or they play more recreational sport, they're quite happy to give this a bit of time. And you might just encourage them to do some things that don't hurt. So potentially getting on an exercise bike, being in the pool, just getting on with their normal day-to-day life. And for most of those patients, they are going to get better. But as you know, there are a variety of things that we can do that can certainly help that process. So in the high-level athlete or people that are more interested in their sport, having a coordinated rehabilitation program is really important. And in general, that starts off with saying, look, let's try and avoid things that are painful. And usually that includes running and doing things even in a straight line. But getting them to do some degree of cross-training. Riding a bike is usually a really good activity to allow people to stay active. So when patients are able to get their knee out to near full extension and can flex beyond about 90 degrees, most people can start doing some spinning on a bike. From there, we get them to do some straight line running, adding in some change of direction running, and then getting back into some sport-specific drills. So having a bit of a plan about what you can do with the athlete or the sportsman to allow them to stay active and engaged in the whole process is really important, trying to foster compliance. As I think you guys know better than me, there are a variety of braces and things that we can use to help facilitate a return to sport or a return to work or just being more comfortable day to day. And a lot of patients with kind of lower grade medial ligament injuries feel much more comfortable wearing a hinged knee brace. And so a lot of my patients that I see that have had an injury, they've come to see me quite quickly. I will put them in a brace just because it allows them to be more active, and a lot of the time they're quite apprehensive and nervous about getting back to activity. So this brace, I'm not using it to try and get the ligament to heal necessarily. I'm just allowing the patient to start feeling more confident about moving, and I'm encouraging them just to feel more comfortable. So it's kind of for pain relief, really. In contrast, patients with a higher grade injury, so particularly patients, say, with what we might call a grade 3 injury, so they're loose or very loose in flexion, and they may have some degree of laxity when the knee is out in extension, I'll typically put them in a ROM brace. And a lot of people will lock the brace up to limit the final 30 degrees of knee extension. And the idea there is that the ligament is under less tension in that range, and it's more likely to heal. But my own view over time, having seen a lot of patients, is that patients don't really like that. And I don't think that necessarily it facilitates them getting better quicker. I don't think it improves their outcome too much. So my own personal take is I'll put these patients in a ROM brace, and I'll encourage them to wear that for a few weeks anyway, but I'll allow them to go through a full range of motion, so I won't lock that up at all. And I think that is really helpful, and it provides, I think it allows patients to feel that they're more comfortable. I think it helps them get better more quickly and more predictably. And I usually use that for a few weeks anyway until they're starting to feel more comfortable. And I usually find that patients take that off anyway. So if I'm trying to get them to wear it for 3, 4, 5 weeks, I usually find that by the time they come back to see me, they've taken it off and maybe they're carrying it into the room with them. Surgery is something that I think the patients often have an expectation. They've had this big injury to their knee and they're kind of worried that they need surgery. But as you know, most patients don't need that. As I sort of alluded to in the introduction, there are some indications or some occasions when surgery can be quite useful. For the patient with an isolated MCL, I'd say that it's very rare that patients are going to need surgery or have anything done to the injury. But sometimes with higher grade injuries, the ligament can retract and can become a bit stuck, again, similar to ulnar collateral ligaments in the thumb. And those patients sometimes don't heal very well. And so you can and often you can tell that, or see that that's happened on the MRI scan. And so there may be a decision made to try and reconstruct it or repair the MCL early. And there are some case reports in elite athletes with higher grade injuries. There are some surgeons, particularly in Europe and the United Kingdom, who are involved managing these very high profile, high cost footballers who decide to operate early on these higher grade injuries as they think that maybe that's a more predictable outcome. So the last thing that these team doctors and surgeons want is to try and allow patients to recover over 8 to 12 weeks, to have them fail and then to have to do the surgery. So the thinking among some people is that maybe we should be operating early just to ensure that these patients have a good outcome. But obviously we're exposing them to the morbidity of surgery and all the risks associated with surgery. So I don't think that's a particularly good idea in the general population. Patients that have a combined ACL-MCL injury are often headed towards an operation. So most young active patients opt to have an ACL reconstruction. And there are two schools of thought about what to do with the MCL. Most frequently, we will put them in a brace and allow the MCL to start healing before we take them to the operating room. But there's again a trend toward taking to the operating room early, reconstructing the ACL, and then if intraoperatively we feel or that it's felt that the MCL is loose or unstable, direct repair of the MCL is something that is increasingly being done. So you kind of got two strategies. One is take your time a little bit, allow the medial ligament to heal and to become a little bit more robust, and then assess whether the patient has instability and decide whether we're going to head off down the track of an ACL reconstruction. The PCL-MCL injury can be a challenging one to heal. So in contrast to the anterior cruciate ligament, where most patients will end up having an ACL reconstruction, but particularly in Australasia, most patients with PCL injuries generally don't need an operation. But the combination of a PCL-MCL injury, particularly when the posteromedial corner is involved, generally doesn't do that well. So most of my patients, I suggest that we start with some rehabilitation. I will put them in a ROM brace and try and get the medial ligament to heal. And I will actively encourage them to get going with some rehabilitation, including some proprioceptive exercise and strengthening exercises for their quadriceps, which I think can be quite effective. Reconstruction of the PCL, surgeons will tell you, is often pretty unsatisfying. It's a hard operation to do, and generally patients still will have some PCL laxity afterwards. But if patients aren't going well and they have ongoing pain and instability, that is an operation that can help. So I guess the take home here is just remembering around the multi-ligament injured knee and being aware that often surgery is something that we should consider. Kids and adolescents are an interesting group. So they generally don't injure their medial collateral ligament. They're more likely to have a bony problem. So I guess I just mention that because I think if you're seeing kids that are skeletally immature, I'd have a fairly low threshold to move them on to someone to get a specialist opinion about whether this actually is a medial ligament injury or is there something else happening. And so, for example, a condition called osteochondritis dissecans, when that happens, it generally happens with kids who are in their early adolescence or early teens. And they'll tip the most common site for that involves the medial femoral condyle. So that is something that will cause medial knee pain, but that isn't a medial collateral ligament. So again, that patient probably is going to have pain when you do a valgus stress test. They're going to have pain and tenderness around the medial aspect of their knee, but their problem is not likely to be a medial collateral ligament injury. And I guess it's important to kind of see how the patient's going. So there are patients who have a low-grade injury who I'll give them some education and reassurance and say, look, don't come back to me unless things aren't going well. But patients with a higher grade injury where there may be some uncertainty about the diagnosis, or certainly anyone I'm going to put a brace on, I think it's really important that you get them back and make sure that they are actually getting better. One of the things that can happen after an MCL injury is that you can develop a Pellegrini striatal lesion. So again, it's something you can see on an X-ray. So a patient who you may have diagnosed with a medial collateral ligament injury who still has pain, or potentially their pain has gotten worse over time rather than gotten better, getting an X-ray or arranging an X-ray for that patient is a really good idea, because you'll often see some calcification up around the proximal attachment of the MCL. So that's what we're seeing with this arrow. You can see there's just a sort of fairly amorphous bit of extra calcification there, and that's been named a Pellegrini striatal lesion. That can settle down with time. Sometimes we'll put a corticosteroid injection up around that. Sometimes that will need some surgical exploration, debridement to resolve. So not all MCL injuries do as well as we think they are going to. but this would be the absolute minority. So, 1 or 2 out of 100 patients. I'm really passionate about prevention. So a lot of these injuries happen in sport, and so we're increasingly aware that we can prevent a lot of these knee injuries. So I work a lot with football, and there's a program that's been developed called the 11 Plus, which is an injury prevention warm-up. And so if we can get patients and players to warm up differently by doing some running, balancing, strengthening exercises, rather than running around and doing some stretching, we can reduce the risk of significant knee injuries by about 50%. So if you look at the anterior cruciate ligament, we can reduce the risk of that in young women by more than 50%, and in young men by about 50%. And that's just by warming up differently. So it doesn't take them any extra length of time. It's just changing the way that people approach their warm-up to sport. So I hope that's been useful. I'm really looking forward to answering some questions, but if you want to get in touch with me, feel free to send me an email. It's quite a long one. And I am on Twitter as well, at Dr. Mark Fulcher. So if you did want to get in touch with me, please feel free to give me a ring. So I think at this point, I'll hand you back to Anna and Tim. But as I said, I'm looking forward to answering some questions and getting some feedback from you guys.
Yeah, thanks for that, Mark. That was a really good presentation. I definitely learned a lot, and I think everyone else did as well. So yeah, really appreciate your time and generosity in coming on and presenting for us on that. So, as you can probably read on the screen, my name is Tim Amor. For those who don't know me, I'm an orthotist with Össur, and I've been tasked with presenting the second half of this webinar. The second component of this presentation will last 15 minutes or so and basically cover the orthotic management options for MCL injuries. Naturally, we'll be exploring the options from the Össur range. And in my opinion, Össur has a pretty comprehensive knee orthosis range and really tends to have your orthotic bases covered, especially with the inclusion of our new MCL brace, which I'll be introducing later. So we'll get the boring stuff out of the way early. The aims of my presentation to discuss the current options available in the Össur range, which will be suitable for MCL injuries. We'll introduce the new form-fit MCL brace and how it fits into the knee injury solutions range. Then we'll go on to reflect on a footballer's experience with bracing following a season-ending injury. We'll also look at the options available for multi-lig injuries and then complex knee injuries before finishing on some of the definitive options, and then we'll go to some questions for myself and Mark. So basically, the overarching goal for all of this is to increase your confidence in managing MCL injuries from an orthotic perspective. So as Mark was saying, ligament injuries, they fall on a spectrum, like lots of naturally occurring data. And in P&O, physio, and allied health, we often divide that up into a grades, which make it a bit easier to bundle similar injuries together. So as Dr. Fulcher mentioned, a grade 1 injury can often manage itself. The force applied to the ligament didn't exceed the mechanical strength of the ligament fibers, and it may have been stretched, but is generally not overly torn. Therefore, there will be not much instability at the knee, and it will most likely feel sore, and there will be a little bit of pain on range of motion towards the extension and possibly deep flexion, and some pain on the valgus stress test. So often this patient won't present to an orthotist or a specialist, and they may just tend to try and suck it up and keep going with their day-to-day life. But if they do seek orthotic management, a sleeve, a minimalist brace, or something like a hinged knee brace might be all that's required to basically help the knee feel better. There can often be a bit of swelling, and a compression sleeve or garment may assist with the pain and provide extra confidence in the knee, which will basically allow that patient to get back to their day-to-day life with a bit more surety. So often that patient will choose no orthotic device as well. So progressing up the scale to grade 2 injuries, and then we find that spectrum framework is especially relevant. So a grade 2 injury can vary from a very minor tear to a nearly complete tear, which is just shy of a grade 3. As such, they can vary a great deal in their presentation and the recommended management. So minor grade 2 injuries can be treated more similarly to a grade 1, and a minimal brace such as a hinged knee wrap may be appropriate. So generally this patient will walk in with a bit of a limp and swelling, but they won't have the same feeling of instability, anxiety, and a bit less pain. So for a more severe grade 2 injury, the patient will have increased pain and that feeling of anxiety, increased instability of the knee. weight bearing might not be tolerable, and a valgus stress test will be painful and the knee will deviate. This patient will need additional support in the medial lateral plane and possibly range of motion control. The best two previous options that we would have suggested from the Össur range are the form-fit range of motion knee and the rebound post-op knee, are both pictured down the bottom there. So both devices have nice long lever arms. They've got the range of motion control option, and you can provide the anti-valgus support. So depending on the referral, we can lock out ranges of motion, and also if you assess the patient and they're having pain in a certain range of motion, we can limit that via the brace. So as Mark said a little bit on, often we have rough guidelines on I guess the extension stop and the range of motion we could use. A frequently quoted number that we see in the literature and speaking to different physios and advice is about 20 to 30 degrees from full extension. So the aim would then to be remove any range of motion stops as the patient rehabilitates and their pain allows. So we could consider transitioning from a brace such as the rebound post-op knee to a more minimalist brace after several weeks for patient convenience and better compliance. So as with all MCL injuries, we're hoping to facilitate early protected mobilization of the joint, which will allow better rehabilitation of the knee and higher quality, better organized healing in the ligament collagen fibrils. Long-term immobilization of the joint for isolated MCLs is generally discouraged and will result in a weaker ligament in the long term. So moving up the chain, and we hit grade 3 injuries. So obviously grade 3 injuries are the most severe grade of MCL injury. It's the complete disruption of the ligament. This injury is initially very painful and weight bearing, and with any movement, it can also be very painful when it occurs. This patient will most likely feel very unstable and require the medial lateral support which a well-fitted brace can provide. The patient may present wearing a Zimmer splint from emergency, using crutches, and have a lot of swelling and tenderness on palpation. The general recommendation for this patient has traditionally been a substantial support such as a hinged knee brace, like the rebound post-op knee, and a starting point could be that 30 to 60 degrees range of motion, then increasing during rehab until the patient can step down to a more minimalist brace, and then hopefully remove the brace completely or transition to a definitive option such as the CTI or rebound dual pictured to the bottom right of screen there. So yeah, the range of motion is often determined by the treating physician. Everyone seems to be different. Mark seems to like to get people back extending the knee more quickly. And I guess a collaborative approach with physio included tends to yield better results. So as mentioned previously, all evidence suggests early mobilization is beneficial for ligament healing when compared to immobilization or locking the knee in full extension. So this grade of injury may require surgery, as Mark said, in which case the brace will most likely be used post-operatively too. So as you may have noted, there's quite a few different options which are available for MCL injuries, especially from the Össur range. But the general principle is that we're looking to provide valgus support and possibly limit the range of motion at the knee. I've also used the word transition a couple of times, meaning the patient may have to purchase two different devices so they're matching an orthosis to their recovery level and function. So this is where the new form-fit MCL brace is a really good addition. So this brace is designed to be used for medial ligament injuries where valgus support is required and can be used from the day of the injury to the day the patient returns to the field, meaning only one device really needs to be bought for the patient. So all the features of the brace are specifically designed around best managing an MCL injury. The lateral strut is extremely rigid, provides support to the knee. The dynamic force strap, which you may have seen on our unloaded braces, provides anti-valgus support and can induce a varus moment at the knee during terminal extension, taking tension off the MCL when it is under increased load. So the brace can also prevent the knee from full extension by 20 degrees and stop flexion at 70 degrees if desired. This adjustment's made with a pretty easy to add and remove set of grub screws, and you can change the range of motion as the patient rehabilitates and progresses through their recovery until it's just free range. Additionally, the brace provides circumferential support and compression around the knee, which helps pain management and is more comfortable than wearing a post-op style brace long term. So the general indications for the MCL brace are grade 1 and 2 injuries. the main reason why we don't suggest it for grade 3 injuries is that a grade 3 injury often is associated with medial meniscus damage. And if we apply a varus force to the knee, we may increase load on that damaged structure. So far, early patient feedback has been really good with the patients we've seen it on and the clinicians that have used it. The patients are able to wear it during the acute phase of the injury, when they go back to work under their clothes, and when they're back to sport training, and just adds a bit of confidence to the knee as well. So where it fits into the range, I've created a nice little chart here. It's basically where this brace fits in and where it can be used. And you see it's across most of the types of injuries which you'll see. But obviously with a grade 3, we need to ensure that there's no medial meniscus damage first, and it probably would be something that we'd do at a clinician or a physician's discretion, going from a range of motion brace to that MCL brace. So we'll move on a little bit from the theoretical to some of the practical, and I thought I'd include a short case study of a young footballer who suffered a season-ending MCL injury just before the finals of this year. The patient has given me permission to use his image and his history. So he's a 23-year-old male. He suffered a valgus injury after a teammate came back with a flight of the ball and landed across his knee. There was instant pain, and he said he felt a tearing sensation. After coming from the ground and being taped up, he tried to actually return to the field, but as he was warming up, the knee kept buckling inwards, and he felt extremely unstable and just wasn't able to run. So his pain increased as the adrenaline wore off, and a visit to the emergency room led to a referral for an MRI, which revealed a grade 3 MCL tear and meniscal damage. He was provided with also a range of motion brace at the hospital, and he actually wore his for 7 weeks, 24 hours a day, except for when he was showering. I think the patient actually reported he got a little bit dependent on the brace and became a little bit addicted to wearing it, because it just really helped his anxiety. The patient reported extremely high satisfaction and said it really helped his knee stability and helped him get back to work. So once he had reduced pain and the knee felt more stable, he stopped wearing the brace now. And at this stage, the MCL seems like it has healed. However, the meniscus might need a little bit longer, as he still has some pain, but he's back to training, and hopefully will be back on board next year playing football. So I'll only touch on this briefly, as it's a little bit beyond the scope of my presentation, and I think Mark will do a much better job covering this in more depth. Maybe we'll get him back to do another one, but he also touched on it. But severe MCL injuries can be combined with other ligament injuries, especially in that active patients with high force incidence. So generally these decisions are made by a surgeon, but anecdotally, as Mark was saying, the MCL can heal conservatively in a brace, and they may attempt to reconstruct the ACL and or the PCL. One such brace which we've seen used in this way is the rebound PCL. So it has rigid uprights for support and can also be locked in the desired range of motion, or be used as a bit of a zimmer when sticking the knee out in extension. So having said that, the typical brace used would be the standard post-op, like a rebound post-op knee. So once the patient has recovered enough, they may choose to use a rigid brace such as a CTI pictured to prevent any undesired or painful movement and to provide that feeling of security to the knee. So as always, we're here to help. We love getting inquiries, phone calls and things like that. So if you've got any questions, don't hesitate to contact me directly at tamore@ossur.com, or you can call the numbers listed below, and we can easily put you in touch with your state rep or someone who can help you out.